Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Boehringer Ingelheim Pharmaceuticals, Inc.
Thank you for joining this Medscape program called From Screening to Action, Addressing Chronic Kidney Disease to Reduce Cardiovascular Risk. My name is Jennifer Green. I'm an endocrinologist at Duke University School of Medicine in North Carolina. And joining me today is Dr. Matt Weir, who is a professor and chief of the nephrology division at the University of Maryland School of Medicine in Baltimore, Maryland. So let's jump into the program. We're going to actually start with a video, a very short video first, that will describe a patient with chronic kidney disease's journey through the discovery and life with these chronic conditions.
Hello, my name is Patrick G, and I certainly want to share my story of living with type 2 diabetes and chronic kidney disease. My journey began in 2003 when I was working then for the Virginia Department of Corrections. I was working as an institutional training officer and a corrections captain. I had been working very long hours, and I was feeling really sluggish one day. And I went to the nurse's station to give her my symptoms. And at that particular time, she asked me, had I ever had a glucose check? And I didn't know what she was talking about. So when she pricked my finger, she looked at the results, walked off. A few minutes later, she came back with another nurse and asked me to surrender my keys. When I asked her why, she told me that my glucose level was at 748. And if I did not surrender my keys, then being on state property, she was going to call the Virginia State Police Department and have me arrested for driving under the influence. So I surrendered my keys. I had an officer to take me to the nearest emergency room, and this is where they took my A1C and found out that my A1C at that time was 11.7. So the emergency room physician told me that I had type 2 diabetes and recommended me to an endocrinologist. My endocrinologist had treated me for 10 years from 2003 to 2013. And the only thing that she really did was to put me on metformin and give me 2 forms of insulin. 10 years later, April 2013, I go to my endocrinologist for just a routine checkup, and everything looked good. She said, "Hey, Patrick, I see you in 3 months." But as I walked out to the parking lot and I'm getting ready to get into my vehicle, my endocrinologist comes running out of her office. And she was like, Patrick, look, I forgot to tell you that you're at end stage renal disease 3B and that you currently have between 30 to 35% kidney function. At that particular time, I did not know what she was talking about. At no time in the 10 years that she was treating me did I know that diabetes was the number one leading cause of kidney disease. So I'm standing there stunned. And she said, Patrick, I'm going to refer you to a nephrologist. A couple of weeks later, I go to the nephrologist. The nephrologist was like, Patrick, you're going to eventually end up doing dialysis. So what we're going to do is to help slow down the progression of your dialysis by having you to abstain from nuts, dairy products, and chocolate. But during this particular time, I noticed I was picking up weight and my urine output was lesser and lesser. Started dealing with a whole lot of mental health and emotional issues. And then we got up to November of 2013, and I go into my physician's office, talking to my nephrologist and saying, hey, doc, I can't sleep. I could barely talk. I was hyperventilating. My wife really had to speak for me. And she asked the doctor, when was I going to do dialysis? So it was at this time I opted to do peritoneal dialysis, and I had the surgery, waited 2 weeks later to recover. And on December the 1st, 2013 is when I actually started doing the very first exchange of peritoneal dialysis. I did this for about 3.5, 4 years, all the way up into April the 21st, 2017. And that's when I got my call for my kidney transplant. So thank you.
Well, before we move on, first I want to express my appreciation to Patrick for sharing his story. But I think my first impression is, my goodness, he certainly found out both that he had type 2 diabetes and kidney disease in a very abrupt and shocking way. I think we're going to talk about approaching the management of these diseases in a way that will permit us to be more proactive and help our patients understand the kinds of risks that they may be exposed to, and what we can do to mitigate the risk of progression of kidney disease and the risk of cardiovascular complications. Matt, you have any other initial thoughts?
Yeah, I mean, this is a very sad but very common story where people who have not had routine screening show up uh, almost at end stage. It's very disappointing. And that's why what you and I are going to cover in the next few minutes focuses on the advantages of screening, education, and then, of course, appropriate treatment.
Yeah, and we'll be back at the end to briefly rediscuss Patrick's case once we've gone through some of the program information. So just a reminder about the significant extent to which diabetes, chronic kidney disease, and cardiovascular disease coexist. And in my clinic, I see many, many individuals who have all of these conditions. Now, unfortunately, the presence of more than one of those conditions in an individual further increases their risk of adverse outcomes. So, for example, if a person with heart failure also has diabetes, their risk of adverse outcomes is greater than someone who has heart failure without diabetes. And of course, if you have all of these conditions, which many, many people do, the prognosis is even poorer. Now, we have many strategies that we've used for decades to address the risks of adverse outcomes in people with diabetes and people with chronic kidney disease and or cardiovascular disease. And these remain foundational therapies. So for example, for a person with diabetes, we need to still focus on glucose management, blood pressure, and lipid management. But there are also newer therapies that can be layered upon that to help address what is the residual risk of adverse outcomes that remains after those traditional therapies are optimized. Kidney disease, a reminder, is a very early and common complication of type 2 diabetes. This figure shows us at the time of diabetes diagnosis, over 7% of individuals with type 2 diabetes already have evidence of chronic kidney disease, so we need to start screening right away. About 50% of people with type 2 diabetes have some evidence of chronic kidney disease, so either an impaired or a low eGFR or evidence of albuminuria or both. And on the right-hand side, you can see that the risk of having microalbuminuria or more advanced stages of albuminuria increases over time. So the longer you live with diabetes, the greater is the likelihood that you will have evidence of chronic kidney disease. Now, if we look at the general population, this slide shows us the prevalence and overlap of cardiac, kidney, and metabolic conditions in adults in the United States between 2015 and 2020. And if you look on the left-hand side, it tells us what proportion of patients in the United States have cardiovascular disease alone, kidney disease alone, or metabolic diseases like diabetes alone. But to the right-hand side, you can see the proportions of individuals with, for example, both cardiovascular and kidney disease, or cardiovascular and metabolic disease, and the proportion on the far right who have all of those. Now, if this slide were to instead focus on the proportion of cardiovascular and or kidney diseases in people with diagnosed diabetes, the proportions would be far higher. But this is telling us more about the overall US population. A reminder that having a lower eGFR is clearly associated with an increased risk of cardiovascular events and death. And you can see, as shown here, the risk of death, to me, visually appears to increase pretty significantly already once the eGFR falls below about 45, and then with each progressive stage of kidney disease, increases fairly significantly thereafter. And there's a fairly similar pattern as shown on the right-hand side of an association between impairment of eGFR and the risk for cardiovascular events as well. Okay, I'm going to hand it over to Matt now to talk about screening.
Well, thanks, Jen. This is why screening is so very important, coupled with education. Again, you hate to see a situation like what happened to Patrick G. Obviously, it would have been nice to know what was going on with him sooner in the course of his disease. Many people have type 2 diabetes for years and don't even realize that they have the disease, as was the case for him. And so really simple follow-up with clinicians, blood tests, urine tests are so simple for screening. This, I think, is just so pivotal. Quite clearly, all adults should have annual screening with laboratory tests, particularly if they have risk factors like a family history for diabetes or if they have hypertension. And it's so easy to screen. A simple laboratory test can tell you about the glucose. You can estimate the GFR from that. And a spot urine albumin to creatinine ratio can be pivotally important in terms of identifying people at risk, primarily for cardiovascular events. And I want to emphasize that there is a linear relationship between increasing urinary albumin to creatinine ratio and all sorts of terrible cardiovascular events. And the kidney events come later. And in fact, many patients with diabetes and kidney disease die of strokes and heart attacks before they develop end-stage kidney failure. And in a sense, then, Mr. G is very lucky that he did not succumb from a cardiovascular event before his kidneys failed. So I think the critical part is screening, educating our patients about the importance of what these tests mean and how they might obviously help us better identify treatment strategies which will prevent cardiovascular and kidney events. I mean, that's the whole idea here, prevent. And so this is why this spot urine albumin to creatinine ratio is so very important, as well as the estimated GFR. The way I like to explain to my patients is that the cleaner your blood, the better. And if your kidneys aren't working well, the blood has a lot of impurities. And these impurities, especially in the setting of high blood pressure, diabetes, and high cholesterol, can lead to accelerated blood vessel damage, and then the strokes, heart attacks, and kidney failure. Likewise, there's a linear relationship and continuous relationship between the amount of albumin in the urine and diseased blood vessels and adverse cardiovascular and kidney outcomes. So that's why these two simple measures can be longitudinally followed in such a way as to guide clinical management, and of course, the main thing being prevent cardiovascular events. And obviously, too, if you have seen, many of you have seen this kidney disease improving global outcomes classification schema on the left-hand panel is decreasing amounts of GFR. On the horizontal panel at the top, it's increasing amounts of albumin. And you can clearly see once that GFR is below 45, as Jennifer mentioned earlier, or that ACR is above 30, These are people at much greater risk. And of course, you can see in the increasing colors there from yellow to orange to pink to red, obviously the adverse outcomes. And this goes for primarily cardiovascular events. And that's what I really want to emphasize here. You can use these two in clinical practice to guide screening. And this is why I think it's so very important for us to consider utilizing annual testing of estimated GFR and urinary albumin to creatinine ratio. Unfortunately, as you can see here, it's not done very often. People need to learn about this. It's so helpful for educating patients. You can monitor it longitudinally. It's easy, it's simple, it's inexpensive, and provides a tremendous amount of opportunity for earlier care and education for our patients. And of course, one needs to be consistent about how we measure it. The labs don't universally offer the same reporting methodology. The reporting formats can be different. But I think if we just remember to order a spot urine albumin to creatinine ratio, this can be really a very important opportunity for us, much as we would order the blood pressure and the A1C moving forward. And so with regard to management, I'll touch on this and then share with Jen Green in a minute. But I also want to emphasize too, as part of clinical therapeutics, meaning using medications, we should always encourage lifestyle improvements. Now, look, let's all agree if you have a 50 or 60-year-old patient in your office who's been eating the same way, has the same socio-cultural approaches to diet, exercise, and living as the rest of his family, and they're all overweight, suddenly having that individual run 5 miles a day is not a realistic possibility. So obviously, we should encourage our people to eat less salt, more potassium, and less saturated fat, stop smoking, try to be as active as they can, and of course, try to lose some weight. But let's be realistic. You can't depend upon this in the majority of our patients. So it does require us to be more proactive about utilizing guideline-based therapies to facilitate better care for our patients. And in the kidney disease improving global outcomes algorithm, as you can see here, there are some preferred medications, largely because they help in conjunction with better control of blood pressure, cholesterol, and glucose in terms of improving cardiorenal outcomes. And of course, at the top of the list would be angiotensin receptor blockers and ACE inhibitors. But then again, for the treatment of diabetes, an SGLT2 inhibitor and or a GLP-1RA would be very helpful because they not only improve glucose control, but also have specific cardiorenal benefits. The use of non-steroidal mineralocorticoid receptor antagonists like finerenone is also a very important adjunct to not only facilitate better blood pressure control, but also to reduce proteinuria. But the bottom line is more intensive control of blood pressure, cholesterol, and then glucose, as you see on the right-hand side of the graphic, is so very important. We should never lose sight of what I call the big three: the blood pressure, the cholesterol, and the glucose, and preferentially to try to employ clinical therapeutics with proven cardiorenal benefits as outlined here. So what I'd like to do now is to turn it back over to Jen Green to speak a little bit more specifically about the American Diabetes Association recommendations, because they're not too different from what we see in the kidney disease recommendations. Jen?
Yeah, I agree. The good news is that there's been much more harmonization with respect to the recommendations for care between the kidney, the cardiovascular, and the diabetes guidelines. And you'll see some similarities here with the KDIGO guidelines. They're a little bit out of sync because the ADA guidelines have been updated a bit more recently than the KDIGO guidelines. And so they've incorporated some of the more recently available trials data. But essentially, and also the ADA guidelines have as a starting place that everyone has type 2 diabetes. But these are the three main pathways that guide us towards the selection of particular agents to improve outcomes in people with, on the left, either established atherosclerotic cardiovascular disease or multiple risk factors for ASCVD. In the middle, heart failure, and on the right-hand side, chronic kidney disease. And on the left-hand side, so the high ASCVD risk individual with type 2 diabetes, it's really very simple, needs to be on either an SGLT2 inhibitor or GLP-1 receptor agonist with proven cardiovascular outcomes benefit as part of their regimen of care. And just a reminder that these regimens and recommendations are irrespective of whether or not a person is taking metformin and irrespective of whether or not a person needs additional glucose lowering. The middle pathway, really easy. If you have type 2 diabetes and heart failure, really irrespective of ejection fraction, you should be on an SGLT2 inhibitor with proven benefit in heart failure. And then on the right-hand side, for people with type 2 diabetes and evidence of chronic kidney disease, in addition to use of maximally tolerated ACE or ARB, now we have two options. They either should be taking an SGLT2 inhibitor or now a GLP-1 receptor agonist with proven benefit in patients with chronic kidney disease. So now we have more and more options. There are lots of questions about whether or not we should be using combinations. The ADA guidelines at present don't say that that is required. However, if a patient with type 2 diabetes in these conditions needs to have the second class, so for example, if they're on an SGLT2 inhibitor, if they need another class of drug to achieve their glycemic goals, certainly it is very reasonable and in fact probably a highly appropriate choice to add a GLP-1 receptor agonist for additional glucose lowering and we think additional CKD outcomes benefit. All right, and just a reminder that comprehensive assessment does not stop with screening. We've talked about screening. Remember that the recommendation to screen people with type 2 diabetes for kidney disease once a year at minimum is not new. This is a recommendation that has been in place for decades. It's just for whatever reason proving very difficult for people to accomplish. At your lab, it may be called something other than a urine albumin to creatinine ratio. It might be called a urine microalbumin. That's the case at one of the hospitals where I work. Or in some locations, you can get a urine protein to creatinine ratio. Whatever you're able to access is what you should order. We also need to, once we have identified that a person has either a sustained eGFR below 60 or any elevation in their urine albumin to creatinine ratio for 3 months or longer, we need to make that diagnosis of chronic kidney disease, and that diagnosis needs to appear in the chart. In general, when large surveys of EHR data have been performed, a lot of the time, people don't have an identifiable diagnosis of chronic kidney disease in the chart until they're at stage 4 or 5 kidney disease. So we need to do a better job documenting that CKD is present much earlier on so that every other provider is aware as well and can make appropriate decisions based upon the fact that the person has CKD. People need to be educated. This is one of the things that is such an important result of screening and early detection. The person needs to find out that they have diabetes or kidney disease before the condition is very advanced or uncontrolled. We've talked about management options, but even once you have started appropriate management, we need to monitor and in particular trend the progress of kidney disease over time so that we fully understand and react to each individual person's risk. So we have some take-home points on the slide. Matt, do you want to walk us through some of these, or do you have other take-home points that you'd like to emphasize?
Well, I think the main issue is the first two: screen and then educate and explain to patients why you're doing what you're doing so that they understand and can be vested in their clinical care. And I would say my goal is to prevent cardiovascular events because, you know, the statistics in our country are that 80% of people with diabetes and chronic kidney disease are much more likely to have a stroke or a heart attack as they are to have their kidneys fail. So I wouldn't say the goal is to prevent end-stage kidney disease. It's to prevent them from having a cardiovascular event first. I think that's the main take-home point.
Got it. And we certainly have the potential to delay the need for dialysis as well. So, one thing I do want to make sure that our listeners understand is that heart failure poses a very significant risk to people, in particular with type 2 diabetes and chronic kidney disease. And we have many interventions that can reduce the risk of a person even developing heart failure along that pathway of chronic kidney disease. So there's lots that we can do to meaningfully intervene. So we have about 5 minutes left to answer your questions, and I'm not going to go in any particular order, but I see one question that I'm just going to take because it's sort of near and dear to my practice. So, are there any data for incretin therapy in the setting of chronic kidney disease? Well, yes, there are. And I would say the best example is from the FLOW study, which assessed the impact of semaglutide therapy compared to placebo in people with type 2 diabetes and established chronic kidney disease at high risk for progression and who were also at high risk for adverse cardiovascular outcomes. And in that trial, which was large and relatively long-term, semaglutide therapy very significantly reduced the risk of cardiovascular events and in clinically important progression of chronic kidney disease. And that's why that third pathway that I showed you in the ADA guidelines now lists GLP-1 receptor agonist therapy as a very reasonable option for patients with type 2 diabetes and chronic kidney disease. So it is nice to have choices. For example, not every person with chronic kidney disease can take an SGLT2 inhibitor. Now we have an excellent and clearly proven alternative in the form of a GLP-1 receptor agonist that can be considered. I'm going to give you this next one, Matt. So oh, go ahead.
There are a couple of them there that are more or less tied together.
Yeah.
One question is, should albuminuria be treated as aggressively as blood pressure and hyperlipidemia? And then the other one has to do with albuminuria, but a normal GFR. Well, first of all, let me take the last one first. Both are cardiovascular risk factors, whether it's albuminuria or reduced GFR. They are associated with accelerated aging of the circulation and increased risk of cardiovascular events. So if you have high albumin, obviously you have a kidney problem. And if the patient does or does not have diabetes, if it's a lot, you probably should have a kidney biopsy to make sure there's not another form of kidney disease in addition to the diabetes going on. But they should be treated, very much so. I treat blood pressure, glycemic control, and lipids aggressively in all patients with albuminuria and or reduced GFR automatically. They need more intensive strategies. The beauty of albuminuria is that you can monitor the response to your therapy. Many of these cardiorenal protective therapies are associated with a reduction in albuminuria. So you can use reduction in albuminuria as a sine qua non of some success that you're actually having a difference in terms of their clinical outcomes. And this has been shown time and time again in clinical trials. So yes, I would say I would treat all of these risk factors. And of course, lowering blood pressure also lowers albuminuria. So better blood pressure control is always important.
So just out of curiosity, is your goal for treatment of albuminuria to reduce it ideally by 30%, or do you try to eliminate it altogether when possible?
Well, the studies clearly show in people with advanced diabetic kidney disease that if you cut the rate of albuminuria or cut the rate of albuminuria in half, the risk of ESRD goes down by half, and the risk of incident heart failure goes down by half, which you mentioned. So it's good for the heart and the kidney. But clinically, I mean, I can, in some patients with some use of these newer therapies and lower blood pressure goals actually reduce the albuminuria by 70, 80, 90%. It's almost impossible to make it go away completely, but I can definitely reduce it quite effectively.
Excellent, thank you. And here's another good question. At what stage of CKD when in a person with kidney disease should we refer to nephrology? This is the eternal question.
Well, let me just say this. The risk for cardiovascular events goes up at a GFR of 45, Jen, as you had mentioned. So clearly anybody who is caring for people in internal medicine or primary care or NP, PA, whatever, again, blood pressure, cholesterol, glucose control is appropriate. But anybody with declining GFR, anybody with more than, let's say, 300 milligrams of albumin in the urine, anybody with a genetic history of kidney disease, anybody with a GFR below 30, they should all be seen by a nephrologist.
All right, fantastic. Well, we have come to the end of our time. I'd like to thank everybody for participating in this event. And to earn your credit, please click on the Earn Credit icon or scan the QR code that you see on your screen. Thank you so much. We appreciate your interest in learning more about this topic.